Good morning, everyone. My name is Oliver Marin from Madrid, Spain, and I would like to thank the organization committee for the invitation to this fantastic meeting. I apologize not being there in person and enjoy your fantastic country. We are going to talk about robots in total hip replacement. What's the evidence? These are my disclosure that do not affect the following presentation. The main goal of this talk is to establish the current situation of robotic system in total hip arthroplasty and establish the current evidence of this topic. As introduction, we can show you this video that establishes the robotics actually in orthopedics. I think we have a huge technology and very costly, but what is the evidence now? Are we playing a game like in this video with this high quality situation? And are we doing this fantastic surgery with these tools in the proper way to benefit our patients? So, what are the evidence with this technology?
Beleza?
This is a
Tomando
historical
café aí?
view of
Hã?
this robotics.
Agora também não veio mais, tá travado aí,
In
tá?
1985, this pulmonary
Acho que eu
surgery
vou
do neurosurgical biopsy.
desligar e ligar de novo.
In 2012,
Bom dia, mãe.
85% of
Oi.
prostatectomies in US
Bom
have
dia.
been done with this robotic assistance.
Normal, iPhone 13, nada demais.
2018, the global market of
Ô,
robotics
eu preciso aí qual e-mail que eu ativo o teu celular,
billions.
o teu iPhone, o teu iPad?
Let's move to the orthopedics and total hip arthroplasty. There are active systems that perform the task without direct human manipulation. And there are other passive systems that must be directed by a surgeon to perform this task. As you can see there in this slide, the Omnibotics or Da Vinci surgical systems that are passive systems. But most in orthopedic are semi-active systems that constrain the surgical manipulation and restrict what the surgeon can do with this surgery. Some examples are ArcRobot, as you have seen there, just for training proposal actually, no longer in use, and the Mako robotic in total hip arthroplasty. So we can divide these robotics in direct ones that could be autonomous, where the robots do the cuts in the bone. Other are haptic, that the cut is under the guidance of the human and there is an haptic boundary, and the boundary control, that when you are doing the bone cut, the system can shut off when the boundaries exist. Other systems are indirect. One is when the robots hold the cutting jigs. Other are haptic, when the robots hold the cutting jigs within an haptic boundary. And this system with the boundary control, where the robot's machine features into the bone to receive the cutting jigs. All the current systems are included in one of these groups. Let's move to the disadvantage of this robotic in total hip arthroplasty. So mainly is the cost. I mean, there is an increased cost and no warranty of decreased complication actually. Also, we need an additional image, especially the CT, that could increase the radiation exposure for the patient. And potentially there's an increase in the surgical time with this new technology. Let's see the advantage. Of course, the accurate preoperative planning is an advantage. We think about the case, we think a lot, indeed, because we checked the discrepancy in a very accuracy way. We checked the size of the components at the femoral side and on the acetabular side, and we check all the measurement in a 2D and a 3D dimension. We then move to the intraoperative OR, and we check with these marks the femoral part and the acetabular side. With these references, we can reproduce the preoperative planning into the OR. And finally, we can do an accuracy bone cuts and an accuracy implant position at the acetabular and at the femoral side. What about the measurement that we can improve at the femoral component? We can improve the offset, the anterior and the lateral offset. We can be an increase in the accuracy of the size of the components. Very importantly, the leg length. We can check the leg length and also the femoral head neck cut, and some of the softwares and technology can do the bone cutting, the milling in the femur and the rimming at the acetabulum. In the acetabular component, we go directly to the last rimming in most devices. But still we need to pressure at the acetabular side, but we use the guidance of the robot to do the implantation of the acetabular component. What about the clinical results are better? So actually we will see with the following part of this talk. Let's see about the publications about that. There is a huge increase in publications about robotics in orthopedics in the last years. But if we look into these articles, only a few devices are used in total hip arthroplasty, and very few papers have been published about total hip replacement. There are several options to use in orthopedics, but not all of them are available or are occurrence for the total hip replacement. Most papers are one institution papers and one referral by same surgeon. And if we see this paper, a recent paper published in JBJS, we can see that these papers published about total hip arthroplasty and robotic assistance could have a risk of bias. Let's see this interesting paper published in 2021. It's a review of several meta-analyses, and they mention in their conclusions that it could improve the component positioning, it could improve the intraoperative complication, but it extends more than 20 minutes in a standard surgery and could increase the risk of heterotopic ossification, dislocation, and revision. In the same paper, they mention that there is no clinical difference between robotic and assistant and manual one, but there are some limitations in this paper. They do not differentiate between all designs and active and semi-active systems, and they didn't take into consideration the experience of the surgeon. This is another interesting paper, a systematic review and meta-analysis published in 2021 that mentioned that in these 17 articles there is an increase in accuracy in implant placement, a reduce in the leg discrepancy, but there is no difference in complication and survivorship. The problem is this study only mentioned two systems, the Mako system and the Robodoc, and both had very important technical difference and could be an important bias. This is an interesting study of a single institution with multiple surgeons that could be more similar than our daily practice. It was three groups of patients. One was robotic, another one navigation, another one manual, and there were more than 13,000 posterior approach total hip replacement. They didn't find any difference in intraoperative fracture or complication rates, no difference in infection or loosening, but they can see an improvement in the dislocation rate if you use robotic. So robotics decrease the rate of the dislocation in this posterior approach total hip replacement study. Finally, let's go to the take-home message. Robotic in total hip arthroplasty is a new technology that could increase the bone cut accuracy and have a better implant position, especially at the scapular side. But we need further better quality studies to conclude that this better position of the implants had better clinical results in our patient after total hip replacement. I would like to invite you to our SOTCOT meeting in Malaysia next September. You are very welcome. Thank you so much for your attention, and I hope next year I could stay face to face in person in your fantastic meeting. Thank you so much from Madrid. No discussion?
Thank you, Oliver.
Yeah.
How are you today? Here's Sofiane.
Fine, Sofiane. Thank you so much for the invitation.
Thank you very much. Thank you very much for your presentation. It was very interesting. The only remark that I have is that definitely the robot give us an idea about more precision in arthroplasty. Nevertheless, it doesn't give you an idea about soft tissue. And I think this makes the difference between robotic and non-robotic, and the robotic doesn't have the appreciation of the surgeon. Definitely, it decreases the risk of dislocation since there is better positioning. Because either the surgeon has a lot of difficulty to appreciate the depth, for example, of the cup, or the length of the stem, but sometimes even the stem is well positioned, but you have a remaining soft tissue release or something like that that could be cause of dislocation. That's why I think at the opposite of the knee, the positioning of the arthroplasty in the hip is much more different because the component of soft tissue is much more important. In the knee, it's much more mechanical. And in the hip, the soft tissue is very important. What is your opinion, and Vikas? Thank you, Vikas, for being here.
Hi. Sofiane, you are completely right. I mean, I agree with you. For the hip, it's so important, the soft tissue. To be honest, in the last update of the software of some systems, they include some parameters that can check indirectly this soft tissue balance. When you plan this patient with the offset and the leg length, you can assess very precisely this soft tissue balance. But at the end, I agree with you. I mean, your feeling is so important to check the instability there.
Thank you. This is Dr. Langi from Libya, our colleague.
Hi, how are you? Thank you for your nice presentation. Just asking about the learning curve, how long it takes to be good in that.
That's a very good question, and it's a hot topic in the literature. There is a mantra that everybody say that 30 cases are correct for every surgery in orthopedic to improve your learning curve. But actually, there are so many different softwares, and they are updating every 1 year the software that you have to learn again about the new modification of that. So actually, the software is free for the surgeon to modify some parameters, but the main problem with the learning curve is to take the points correctly. When you do the marks, the checks that you have done intraoperative is the main problem. And the learning curve for that is different from different designs. But at least I would say that you need more than 30 cases to be comfortable with the software.
All right, thank you very much for your answer.
You're welcome.
What is your opinion, Vikas?
My opinion is that we have it, we use it for a certain cases. I think for a unicompartmental knee replacement, I have no doubt in my mind that this is the best way forward. I think for a total hip replacement, in my hands, I do not see a major value of the robot at the moment in its current state. But the new software in terms of spinopelvic biomechanics that Mako has got, I think that may certainly make a difference. So we are evaluating that at the moment, and that potentially will be the game changer. But in its current state, I don't think it adds huge value for the hip. But for unicompartmental knee replacement, definitely no doubt that it is a game changer.
Thank you very much. Thanks again, Ben, Oliver.
See you next year.
See you. Bye-bye. See you next year. See you in Kuala Lumpur.
Yeah, sure. See you.
Sure. Okay, thank you. Next.
Thank you very much, Sofian, for the kind invitation. And I'll start off with the next talk, and that is advances in surgical training and the value of virtual reality.
Okay, thank you.
Bring you greetings from our biomedical campus in Cambridge, and would be more than happy to welcome any one of you who would wish to come here and spend some time with us. These are my disclosures, and none of them are particularly relevant to this talk. So surgery as we know it, if we look at it, surgery in the past, we've obviously basically learned on the apprenticeship-based model. We spend a lot of time with our seniors in the operating theater, and that's how we learned. But obviously it's changing because the complexity of the surgical procedures is increasing. We are doing a lot of stuff arthroscopically. The training period that we have, at least in Europe and UK, has decreased. And from an apprenticeship-based model, we are actually moving on to a competency-based model. Now, if we look at the theories of learning, how do surgeons actually learn? Then the first model that comes to mind is the Fitz and Posner model of attaining procedural competency. Now, they divided it into 3 stages of the cognitive phase, where the surgeon would know and knows how to do it, basically the learning aspect of it. The integrative phase, where the surgeon would actually show how to do it, and the autonomous phase, where the surgeon actually is doing it on an automatic level. So that's the Fitz and Posner model. Now the third bit, that is the doing model, if we apply another theory to it, and then we need to look at the Erickson's theory of deliberate practice. And you can actually break down your operation and take a specific skill. So you identify a skill component, then you do focused practice on it. And then as long as you're doing a focused practice and your trainer is standing next to you and giving you immediate feedback, then that is the theory of deliberate practice, and that's how you become a master in that technique. Now the question is, how do you apply this model along with the issues that we have on training and use something from the airline industry, which they have been very competent and have done extremely well in terms of a simulation. So enter the era of virtual reality. And how can we actually look at VR in surgical interventions. Now, if you specifically look at VR, it describes the computer-generated simulation of 3D environments that can be interacted with in a seemingly real or physical way. That's the true definition of VR. Now, for this purpose, we basically looked at hip arthroscopy because that is what I do a lot of. There's a steep learning curve in hip arthroscopy. It's clear that the outcomes are worse and increased post-operative complications and also operating times in arthroscopic procedures performed by inexperienced surgeons. It's also true that there's a high incidence of chondral damage and perennial injuries in hip scopes performed in the first 3 years of training. And there is a clear mandate for a strategy to overcome the initial learning curve. So that's why we wanted to take hip arthroscopy and see if we could use simulators in training for hip arthroscopy to actually improve the training. And simulators are of two kinds. You've got the high fidelity simulators, which make you the real feel of exactly what's going on in the operative field, or you've got the low fidelity simulators, which you can practice. So for this purpose, we use high fidelity simulation. Now, training ideally should have all these components where you have cadaveric skills training, you've got simulation training, obviously the cognitive base, which is the knowledge base in the pathology that you're treating, and obviously a clear fellowship for a year or so in the specialty that you want to train in. And then following becoming an attending, you need some mentored independent practice. So what we want to focus on now is simulation training. So what we wanted to look at is, are these simulators validated? And what's the evidence actually that all these companies who are making simulators, are they worth use in training? So when you test the validity of anything, or testing specifically the validity of these simulators, you have 4 types of validity. You've got the face validity, you've got construct validity, content validity, and concurrent validity. Now, face validity is about how real is the thing. Construct validity is about how effective are the variables measured at differentiating the levels of procedural skill. Can it actually differentiate if Sofian is operating to specifically a trainee who is operating? Can the simulator do that? Content validity is about appropriateness of the variables measured. And then concurrent validity is really whether, if you trained on the simulator, will it make you a better surgeon in real life? That is the real world performance. So these are the 4 different types of validity. Now we use this simulator, which is the Symbionics Arthromentor 3D system simulator. It's got fixed 5mm portals, 70-degree arthroscope, and a 5mm blunted probe. It's got a computer and a monitor producing 3D images in response to the actions of the operator, and it does provide you haptic feedback via motors connected to the instruments. So a pretty good hip arthroscopy simulator in practice. So the first thing was the construct validity. How effective are the variables measured at differentiating the levels of procedural skill? So we run a hip arthroscopy course annually with ESCA. It's a cadaveric course. It recruited all the participants, both the novices that would come to learn and also the experts who were there to teach. The expert, we used a cutoff of 250 independent hip arthroscopies, and we classified them as experts. And anybody who had done less than 250, we classified as a novice. All of them did the simulation tasks, basic visualization through 21 targets, 3 portals, and also the probing targets. That is 8, and sustained contact for 3 seconds on the probing target as well. Everybody did it independently, and these are the results. So essentially, if you look at the experts, they are in blue, and the novices are in orange. The novices took more time and had more issues in terms of soft tissue collisions and bony collisions on the visualization and probing tasks. And the same thing you can see, this is on the probing task. So the first set of experiments clearly prove that actually it can differentiate between the novices and the experts. So implies that it does have construct validity. Now the second thing was face validity. How real is it? So this was another course, another year. We wanted to check the appropriateness of the simulator's psychomotor ability, responses to questionnaires by surgeons with understanding of the real-world procedure. Again, 25 orthopedic surgeons. We used a diagnostic hip arthroscopy model, 12 specific tasks, and we got them to fill a questionnaire about the level of realism, and we took 0.7 as an acceptable level of realism. Now, all domains were above the 7 mark. 92% of them thought that it was a non-threatening learning environment and they had an enjoyable experience. Over 80% found it to be a useful training tool for interns, residents, and attendings. But the issue was here. Tactile feedback received from soft tissue was not ideal. There's about 50% of them. And that was the main limitation. So it does have face validity, but the main issue was tactile feedback. So that's the second set of experiments. Then the third set was about the learning curves. Does the continual use of the simulator improve your performance with repeated use? So again, we use the same simulator, clear instructions provided with a familiarization period, 7 identical modules over 6 weeks, diagnostic and probing as well, along with immediate feedback. And as you can see, in all these 6 domains, the total time taken, it starts high, then reduces low over 7 weeks, number of collisions reduces, the number of time the tissue contact reduces, femoral head collisions decrease, camera distance travel decreases, and length of the femoral head scratches also decrease over the 7 weeks. So definitely, there was no doubt that this was actually improving your learning curve with actually repeated use. So that's the third set of experiments. And the fourth set was on virtual reality simulation using medical students and to see if that actually sparked up their interest in orthopedic surgery. Again, a set of medical students used here, and I won't go into the details, but essentially it does spark an interest in arthroscopic surgery in medical students over a period of time. And as you will hear, now these have actually moved on to the next talk. You will hear possibly from Danny Cole, and he'll tell you about the new things that are out there in terms of virtual reality simulation for hip arthroscopy, but this is definitely advances in training. If you need to read more, this paper summarizes all our experiments that we've done on this, about 8 of them, about how virtual reality simulation actually is improving training or otherwise. But in conclusion, ladies and gents, what we found from all these experiments was that it's a great adjunct, but haptic feedback is an issue. It may be more useful for earlier stages of training, that is medical students and probably in the earlier years of your residency, that's year 1, year 2. But we certainly need to be more critical with our evaluation on this technology and have the validity proven clearly before its mass usage. And we also need to establish utility before spending £84,000 on buying these simulators. Collaboration with the companies is the key because surgeons need to be working with these companies to collaborate together to actually get these simulators made. A big thank you to all these companies who actually supported us and the research bodies to do all this research. A big thank you to all of you from Cambridge, and do welcome all of you to our meeting in Kuala Lumpur later this year in September. Thank you.
Okay. Thanks again, Vikas. It was very interesting, this challenging topic. If there are questions in the floor, there is funny one and less funny one. I will start by the funny remark that will give you, doctor.
Just because you were pro using virtual reality in hip arthroscopy, but you're against using total hip replacement.
Sorry, I'm pro using hip arthroscopy.
Virtual reality and technology.
But against, no, not at all, not at all. This virtual reality simulation is for training purposes, improving your learning curve in hip arthroscopy. Mako robotics is for total hip replacements in improving your component positioning to spend £1 million to improve your component positioning by 3 degrees and not as a learning tool, I'm not against it, we've got it, but I'm concerned about the utility. And as you looked at my last slide on these simulators as well, I'm still concerned about the utility. Although we've proven that it does have construct validity, it has got face validity, but it still doesn't have, we haven't shown utility of it. So I am concerned about mass usage of these VR, very expensive simulators, and for that matter, Mako robotics as well. I'm fully on board with technology. I would want to work with companies, but I think as orthopedic surgeons, as the mass utilizers of this technology, we need to be very critical and we need to be very evidence-based in what actually it does for you. So I wouldn't say I'm against it or for it. I'm for the evidence in it. That's what I'm saying.
Thank you very much.
The last point, I think it was among the main things that you mentioned in your conclusion is that the young population is much more keen and much more easier to use this technology. And this is, I think, the point which is missing in the studies. And when you compare, for example, expert and non-expert, sometimes a young surgeon who is not really expert could be more active or more fluent in using this technology than an expert who is more than 60 or 70. I think this is the key issue, and we hope that the next few years it will be much less expensive with the mass using, with the training mainly in young population. Thanks, Vikas, again for your dedication. We see you tomorrow in the SOTCOT symposium, and see you tomorrow.
Thank
Bye.
you very much indeed. Thank you. Bye-bye. Thanks for the questions. Thank you. I think Bruno Danny has left, so you might as well do the talk next.
The next presentation with Danny Goel from the United States, but actually he is in Nice. No, this is Bruno Gabato. It's not Danny here. Bruno, you are live? You are here?
Yes, I am.
Yeah. Okay, let's start with Bruno Gabato. Okay.
Okay, I will share my screen.
Thank you very much for being here, Bruno.
Thank you. Do you want to share my screen or we play the video? I think we'll share. Sorry. So, Sofiane,
Yes.
can you see?
Yes, I
everything
see you,
okay?
yes.
Okay, so first I'm very glad to be here online, sharing with you. I'm from Brazil. Actually, I'm now in New York City, United States, also far away from home. But it's very nice to share with my friends around the world. I'm a shoulder surgeon, so I'm speaking more about shoulder, but all the technology I'm going to speak here can be used in any kind of orthopedic field. And we're going to talk about artificial intelligence, AI, in this case for shoulder arthroplasty. This is a AI that I have created. I'm not sure if you're going to listen because the audio may not work. So have you listened to this?
Yes.
Okay. So this is a text this is AI that I have created, and now the AI can replicate any text that I can do. So I could record this presentation text, and using my own voice, the AI could have this presentation. That's where we are heading for. But the objectives for this presentation is to show you guys some terminology and basis for artificial intelligence to you to understand a little bit when you read that article or when you have a presentation about AI, because today everything is AI, everything is AI, every company is saying that they're using AI, and it's not like that for most of the time. Show how we can make our real life examples of artificial intelligence, and maybe show how can you make your artificial intelligence robots for your orthopedic practice. I'm going to show also a free product based on artificial intelligence for shoulder surgery. And of course, the goal is to stimulate you guys to use AI, understand AI, and maybe create your own machine learning or your own artificial intelligence for your own purpose. First, we have to understand a little bit about artificial intelligence. We humans, we learn from experience. So the data is experience. Computers, they need to be told what to learn. So what is the machine learning? Is to teach computers to learn from experience, but their experience is not their life. Their experience is the data. And here I'm going to show some pictures. For example, for us, it's very easy to understand that this picture in the middle, it's a dog and a lady, but they have the same shape. So AI that is not trained will think this is the same thing. And now take a look at this picture. Sofiane, I asked lots of orthopedic surgeons to tell me only based on this picture. Imagine that you have no knowledge before. What is the difference between these two animals? Well, we see it's an animal. And most of the orthopedic surgeons say, well, this in the left is a kitty. It is small. It's a kitty because it is small. Well, we don't have any size in this picture. We don't know this animal is big and small. From the picture, you cannot find that. As we know, and as we have seen lots of tigers and lots of kittens or lots of cats, we know this is a small animal and this is a big animal. But they both have the same color, they both have mustaches, they both have stripes on them. So we have to teach the computer this small difference because the computer does not have the back knowledge that we have to understand and to differentiate between a kitten and a tiger. And how do we do that? Well, we provide data to the machine learning. The best example is when we say supervised machine learning. So what is this? We have data that we know it's true, and we know the output. So we have the input and the output. This example is very simple. I have a picture of a dog, and I know this is a dog. So I will give to the computer a picture of a dog and say to the computer, this is a dog. Now I will have a picture of a cat and say to the computer, this is a cat. The computer will have an algorithm that will try in the understanding difference between dogs and cats, and he'll try to figure out if that's a dog and a cat. But of course, we don't do it with one picture. We do with thousands or millions of pictures. After that, we train the algorithm. This is the training of the algorithm. I'm training how to understand for the computer to figure out a difference from a dog and a cat. And then we test. We grab pictures from dog and cats the computer have never seen in their life, and we ask the computer, this is a dog or this is a cat? And then we can test the accuracy of our robot, of our computers. This is actually how we do. We can do with pictures, but we can do with data. We can do with numbers too. So AI is the big thing. And machine learning, when you say machine learning is using AI examples of artificial intelligence with lots of data science, with lots of probability tests, lots of things that we do for our research is inside the machine learning. There are 3 types of machine learning. It's just examples. The supervised is just as I told you. And here an example of a supervised machine learning I did myself. I grabbed image from my clinic, 3,000 images from x-rays, from everything. So normal shoulder, normal hip, normal elbow, hip arthritis, shoulder arthritis, shoulder fracture. I classified this image, so I know what they are. And then I tested the model, okay? So I trained the model with the computer, and then I download the image from the internet that the computer have never seen and tested if he's correct. For this example, a knee that the computer understands that is a knee. These are the examples, and he predicts how much sure he thinks he are. So he's pretty sure this is a normal knee. In this case, he knows it's a hip, but he's not sure if he has arthritis, and this is wrong. He's not correct. In this case, he knows it's arthritis, shoulder arthritis, and the computer figure out very precise. Sorry, I messed out. And let's move. This is a knee arthritis that the computer figured out correctly. A shoulder proximal humeral fracture, he's correct, and a rib arthritis. And that you can see with very few images, 3,000 images. I did myself, I labeled myself. The computer can learn how to do simple diagnostics. This is an example how I teach the computer to understand movement. This is very raw, very simple. I teach how to understand the movement of my arm. Full elevation, 9 degrees of elevation, or below 9 degrees of elevation. And this is also a training that you can download. So if you have your own phone, you can point to this QR code. It is online, so you can test. This is with a small amount of pictures, and you can test if this computer can give diagnostics from your image. Very simple, as I can see, but we can also share in the internet and do something very easy. After I have my image labeled, I can do this in 10 minutes. It's very simple to do that. And we have sometimes the unsupervised machine learning, is when the computer tries to figure out things that are similar. For example, in this case, the computer does not know this is George Clooney, but he can understand, he can figure out that these three persons are the same person. This is a same person. So this is the unsupervised machine learning. And we have also the reinforcement machine learning, that we give points, that we give goals, objectives to the machine learning. And that's why what automated cars uses for that. The car has a goal to go to one point to another point without crashing. This is the reinforcement machine learning. So here is an example of reinforcement machine learning from Google. We trained it to play that Dino game that Google when you don't have connection. So what the machine do? He does thousands and millions of games. He misses. Now he figures out how to beat that game. And that's how machine learning can do. We can do millions of games in seconds to do and figure out what is the best way to beat the Google game, for example. Also for cars, this is example for cars too. So the objective is to have the car in the longest ride. So this is the objective. So the computer will have millions of cars randomly. The movement is random, just as you see. And then he selects the generations of cars that go far. And the best generation is the generation that we select and won. So this is pretty much like natural selection, Darwin told us. And we are doing the same for computer, millions of generations. But in this case, we can do is do it in minutes. And what we can do that, we can identify complex iterations, we can classify data, we can find how much a feature is contributing for a result. I'm going to show some example. and we can predict results, and that's what we are doing for shoulder arthroplasty. Predict how our patient will be in the future prior to their shoulder arthroplasty. And we have machine learning everywhere, in Spotify, Netflix. When Netflix shows you a movie, it's using machine learning based on your preference. We have for cancer, tumor detection, for x-rays and everything else. And we are using this for this type of implant from Exatec. So we input 19 inputs from demographics from the patient, and using machine learning, we can predict how the patient will be in the future. So, sorry about that. So, how did we did that? With 5,000 patients and 17,000 visits. And this is how the data that we give. We give range of movement from the patient prior to the surgery, pain, and some data. And now we can understand how the patient will be after the surgery, in this example for a reverse total shoulder arthroplasty, and also during his recovery. So I can understand how his active elevation will be in 3 to 6 months, 9 months, and 2 years, and after 2 years. So this is prediction for that patient with that characteristics. If it's a female, if it's obese, if it has diabetes, if it has a too stiff shoulder. So all we take this in consideration, to predict the output.
Okay. Bruno, can you make it shorter a little bit, please? Can you?
Yes.
Okay.
I'm just ending.
Okay.
So what we can see that for image diagnostics, we can see artificial intelligence for defining fat in muscle. So this is how we are using artificial intelligence in orthopedic surgery. I will end my presentation here.
Okay. Thank you very much. Thank you, Bruno, for your presentation. Thank you for your dedication and being with us live from Brazil, from United States now with all this difference of time. It was a great pleasure to have you in our meeting. We see that AI remain in early stage, I say, because it's for most of surgeons, it's a little bit complicated to introduce, and we are, I really admire the way that you make it much more easier to be explained and to show how it is difficult to do the simulation and for the machine to understand exactly what we need and the application for shoulder surgery. I hope that in our next meeting we will invite you live or to be present in Tunis and to present mainly the application in shoulder arthroplasty. Then hope to see you again soon.
Thank you, my friend.
Thank you, Bruno.
Very glad to be here.
Okay, thank you, Bruno. Thank you very much. Bye-bye.
Ciao.
Hello, and thank you for allowing this talk to be at the Tunisian Orthopedic meeting. My name is Christy Weber, and I currently serve as the International Orthopedic Diversity Alliance President. I'm talking about why diversity is important, and we know it matters in the corporate world. It's also important in any type of political, educational, or other system, because the benefits end up increased profits, increased innovation, better creativity, reduced employee turnover, and these have all been documented in the literature. It allows us an ability to serve our community with different voices, to challenge the way things have always been done. Why the diversity matters in orthopedics is because we have such a difference in the gender and race makeup of our field. It is really very few women and very few underrepresented racial segments. The field doesn't reflect the patients that we take care of, who are of all different genders and races and ethnicity. We are often missing out on the best and the brightest medical students because they choose other fields. They may not think that the field is right for them if they don't see someone that looks like them. And we risk losing relevance to either prospective surgeons or patients. And I think that if we have critical assumptions that everyone has equal rights regardless of their differences in gender or race, and if they've met the criteria to enter orthopedic training and they can become good orthopedic surgeons, we should be able to have an open view on who can join our field. So I'm often asked if diversity matters, how do we get to a point where we can call ourselves diverse? What would that be? And I don't think that there's a number that we need to look at, but we need to try to decrease barriers to admission of either qualified applicants to our training programs or to people rising up in leadership. And there's a dilemma that one way we could recruit more women and more underrepresented people, and that might change our culture. But sometimes people just do that to check a box, and the environment really isn't very inclusive. And so I think it's more important to change our culture and to make it a welcoming and inclusive environment. And that way, more people will want to join us from more underrepresented groups. So I feel that we have a bit of a culture problem in orthopedic surgery, and I'm speaking from the United States, but I think that there's a bit of a culture issue around the globe. And the majority culture, at least in the United States, is primarily Caucasian men, heterosexual, conservative, and I think that people who don't make up those groups sometimes feel like they have to fit in. There's a wide variation of who's in our training programs. Some training programs are very diverse and some are not, and then they tend to replicate that same pattern. We see bias and microaggressions with some people who don't look like the majority being treated as less than. And sometimes we still define leadership in male terms. And so women have to walk that line of gender norms that is very difficult. And also the leaders of our institutions and our national societies are older in many cases, and diversity and inclusion was not a priority when they were training, and therefore they don't necessarily see it as a priority now. We also have to be concerned about the culture that we have in patient care. So our patients often expect orthopedic surgeons to look a certain way, primarily to look like they're men. And that becomes a source of distress to those of us who are practicing. So what can I do? Well, I think that what we can do as individuals is we can commit to being interested and curious in people who aren't the same as we are, acknowledge our biases, take a break when we slow down. We're better able to question our assumptions, asking about other people's experiences and listening to their story, knowing who works in your building and their names, speaking up if we see bad behavior or harassment of either colleagues or patients, committing to creating change to make a more welcoming environment, suggesting ideas related to family leave or lactation rooms, to suggest that panels and symposia are made up of diverse speakers. And if you're a leader of your group or your department, really committing verbally and frequently about an inclusive culture, modeling good behavior so others can see you, and elevating and empowering diverse individuals to visible roles. On a local level, if you're recruiting new people to build your group, having diverse people on those recruitment committees is important to identify diverse candidates and set the strategy and the qualifications before you start looking for the individual. Having structured questions, knowing the policies that may be important to women, and having parity or equality in compensation and resources for the roles. On a national side, orthopedic organizations should have a strategic plan that includes metrics for diversity in their organization. They should really have a good discussion about how leaders are selected and whether that's transparent and that advantages everyone. And again, an intentional focus on having diverse panels and webinars. So I think it's important to seek all perspectives when we're presenting, and it's pretty easy to do in this case. As you see on the slide, this is a diversity webinar, so that's easy to get diverse people, but we should have diverse panels even when it's not for diversity related programming, when it's for clinical programming as well. So this is a picture of the American Academy of Orthopedic Surgeons past president's dinner, and that is not a very diverse picture, as I am the only one in a dress. This is what we'd like our orthopedic culture to look like so we can represent the patients that we take care of. And I think we have to be able to evolve to this new culture, or we are not going to survive as a field. And I would just ask that we work to change the culture together. And the IOTA group, International Orthopedic Diversity Alliance, is really moving forward in a global capacity to try to create a culture where everyone can thrive. Thank you very much. Okay.
Thank you, Christy. I'm Dalal Bouchet from the Middle East.
Thank you.
Is that okay?
Yep. So Christy is our president, and she was the head of the American Academy of Orthopedic Surgeons in America, of course. And the next speaker would be Dr. Jennifer Green, who's a hand surgeon in Australia, who's our vice president. And she will also talk to us about diversity. You can start the video, yes.
Thank you very much for the invitation to talk today. My name is Jennifer Green, and I'm an orthopedic surgeon from Australia and the Vice President of the International Orthopedic Diversity Alliance. The International Orthopedic Diversity Alliance, or IOTA, as we call it, is an organisation that is championing diversity, equity and inclusion in orthopaedics worldwide. We're a group that was founded in 2019 as a collaboration of 45 surgeons from 30 different nations, and we have now grown to almost 1,000 members across the world, including 50 past and present presidents of orthopaedic associations globally. We know that organisations with more than 30% diversity attract the top talent, they're more innovative, and they make better decisions. Diversity matters so much in orthopaedics because we are the least diverse medical specialty almost in every nation, and lack of health workforce diversity leads to healthcare inequity. At present, we are mostly selecting future surgeons that don't represent the diversity of our communities. We know that from US studies, racial diversity is a big issue. There are high rates of amputation after lower limb trauma in Black Americans. They also have poor access to joint replacement and poor outcomes after joint replacement. And a lot of these differences have been attributed to poor cross-racial communication. There are several studies in Canada and the US that have shown that women with the same symptoms of arthritis are between 2 and 22 times less likely to be offered a knee replacement than a male patient with the same symptoms and same x-rays. Across the world, we're gathering data about how many women are in each nation and what percentage of orthopaedic surgeons they make up. But we know that there is almost no nation across the world that has reached 30% to have a useful diversity influence. Our organisation is a not-for-profit, championing diversity, equity and inclusion, and we are aiming towards a global orthopaedic community in which everyone can thrive. We're uniting and collaborating diverse allies across the world. The actions we're taking, including creating networks in every region, in Africa, the Asia Pacific, Europe, Latin America, and we have hosted symposia at the American Academy in March. We have also hosted a webinar with the British Orthopedic Association, and will be attending the EFORT meeting where we have a large diversity symposium later this month. We are creating educational webinars, and we are also collaborating with many organisations across the world, including SOTCOT. We have a large number of online diversity resources on our website and are very active in our social media presence. Anyone can join our organisation, and it is free, and you can use this QR code on the right to sign up. We know that it is important to have visibility for those underrepresented minorities. Having visible role models has a very strong influence in engaging, particularly with women who may consider orthopaedics as their profession. We know that there are many unconscious biases and implicit messages, particularly at university, such as women don't do surgery, or surgery is a boys' club, or that women cannot have a family and be a surgeon. And this is the #1 reason female medical students do not choose surgery. We know this as the hidden curriculum. We know that events that encourage women to consider a surgical career have a very positive impact on engaging, and we've done a lot of work on this in Australia. There is also a lot going on in other nations. Mentoring is also a priority, as women are less embedded in networks. They lack crucial information and useful contacts. They're often unaware of opportunities. And we know that men and women are equally likely to accept promotion, but men are 50% more likely to be asked. We need to give similar feedback to our male and female trainees. We know that a lot of research shows that the feedback to men shows a clearer picture of what they're doing well and more specific guidance on what is needed to get to the next level. And this applies to orthopaedics also. What do we do when and how do we respond to pregnant trainees and provide flexibility? This is an important issue for women who are mostly training during their childbearing years. So what can you do as a surgeon in charge of trainees and medical students? Share what you love about in surgery with everyone. Invite your students and junior doctors to theatre, include them and teach them and inspire them to enter orthopaedics. And do this without bias and recognise your own unconscious bias. We will all benefit from greater diversity. We will attract greater talent to orthopaedics, we will increase our innovation, and we'll all make better decisions. Diversity in orthopaedics, most importantly, improves equity in healthcare. So we can move from equality to equity, and one day there will be no barriers. Finally, I'd like to finish on a quote from Simon Fleming, one of our board members, who has just finished his training. Being an orthopaedic surgeon is a privilege. We are able to change people's lives, and yet we are still not representative of the communities we serve, nor those starting their journey as clinicians. A diverse, inclusive and equitable orthopaedic culture is one where everyone feels they belong, where patients, whether they are patient or a member of the profession. That in turn will mean better outcomes, a happier, more fulfilled workforce, and generally a better, more innovative global healthcare community. Please join IOTA, and thank you for your time.
So hi everybody, good afternoon. So I'll be talking a little bit more about the Middle East. So before starting with the Middle East, do you know, as Jennifer was saying, the best diversity place would have 30%, let's say, females. So do you know which is the best country in the world that has best diversity in orthopedics? Which country would guess? They have more females around the world. Guessing? United States, you think? Where? Until my presentation comes up. No? Can I have my presentation? Okay. Somalia, it's not in Africa. No. No. So somewhere in Europe? Yes. Ella, it's there. في شنطتي الفلاش. So it's Germany with 27%. So it's not even really 30%. طيب, Middle East. طبعا يعني ولا ما كان جيت. So yes, we are underrepresented around the world, and especially in the Middle East. So we are less than 30% everywhere. And in Saudi Arabia, we are 3%, and the trainees are 17%. I wanted to show data. I'm just waiting for that presentation. It's called Diversity Tunisia. So why do we need diversity? So Jenny was talking about that. You have the best talent. You wouldn't miss on Marie Curie if you didn't have diversity. So so these are the this was published in the Effort 2020, and it shows that Germany has 27%, and next is Estonia and Spain. And you can see that the Middle East is nowhere there, and we have the worst diversity ever. Sorry, it goes this way. So this is the Middle East numbers. So are they acceptable, do you think? So in Saudi Arabia, we're 95, but the next place, not even 2 digits. So 7 is in Tunisia. Sorry, 6 in Tunisia, and 7 is the maximum number. So we need more girls in orthopedics, please. Now, أكثر? In Libya, I couldn't find in Libya, nobody was answering me back from the association. So these are the girls that I could get on LinkedIn and Facebook. You are more than that? طيب, around 10. طيب, 10. طيب, give me a number. Okay, so we will have our contact and we will build it up. Okay. I hope so. Okay. In Sudan? No. طيب. For everybody, the problem is the associations are not very cooperative. So when you ask the head of the association, nobody would give me a number, and I'll have to look people in Facebook and LinkedIn. You gave me the number for Tunisia, Morocco, and most places. Our country is young, so Saudi Arabia, I know we're younger than most of countries in the Middle East and North Africa. We're just 91 years old. As I said, we're 3% as female orthopedics, but if you count trainees, we are 17.2. So we're more than the US. We have females in almost all specialties except trauma and military, which is, again, one of the things that we cannot get into. So what are the issues of diversity in the Middle East? From asking the ladies in orthopedics, number one problem is being accepted in the program or in the board. Difficulty to get into subspecialty, and as Jenny was saying, everybody is scared that there's an issue with getting married and having kids, and we don't have the global problem of different pay. We have equal pay, but we're not accepted to start with. We have a big gender bias. It is a male-dominant society, whether we like it or not, whether we say it is not. It is a male-dominant society. The patient would always guess that I'm the nurse, I'm not the physician. And male colleagues would always tell me that I'm not strong enough. Even if it was a joke, I don't think it is a good joke. It's not funny. The initial struggle of ladies in the Middle East, we had different stories. So one of the ladies had to apply 3 times for 3 consecutive years just to get accepted in the program. One of the ladies had to stay 1 year unpaid just to get to prove herself in the program that she can finish that program. And initially in 1998, the first ladies who got into the program were bullied and they were hazed into getting there. But those are the faces of the role models that we need to salute in the Middle East. We need to give them the share of respect. So we have from Egypt, Bahrain, and Dr. Zainab from Iraq, and Dr. Emil, they started in '98. still with low numbers eventually, but they started earlier. And the rest of the ladies, they are there. And yes, please take pictures, send it everywhere, put it on every social media there is. We need to salute them. Now, what do you think the biggest issue in orthopedics? I was talking to most of the colleagues who are in higher association and are chairpersons of the associations. And everybody is scared that if women get into orthopedics, they will drop out. They will start for 1 year and then they will leave the program. And this is what everybody gets from one or two bad examples. So how can we fix this? We need to mentor medical students before they get into the program to decrease dropouts. So what do we do in Saudi Arabia? We do something called Career Day, where if a physician or a surgeon from each specialty, you can see pediatric surgery, plastic surgery, orthopedics, and medicine, a representative will go to the medical school for 1 day, and the student will keep asking about each and every details that they need to know about. We mentor through research projects. So medical students, while they are doing the research project, they can see the different specialties and what is there and what is available and what is new. So this is one of the groups that I mentored 2 years ago, and I can proudly say that 2 of them are orthopedic surgeons in the board now, and 2 are general surgeon. And I'm happy about the general surgeon like the orthopedic surgeon, because it means that when they chose it to the correct reason. They didn't choose it because it's just fashion. We mentor through summer programs. So during the summer, when medical students are a bit relaxed and they don't have an exam, they can come to the department for 6 weeks. Attached to different units, they can choose 2 subspecialties. They take on-calls, they go to the clinic, they go to the OR, and they try orthopedics on as a physician rather than just a medical student who's having a lecture and an exam. Like what Jenny was putting, we do courses for medical students to understand the fun part of orthopedics. The fun part is not the lectures. They sleep through the lectures. The fun part is drilling and arthroscopy. So these are the initiatives around the world. There is a big PERI initiative in the United States where they teach medical students and even high school students about orthopedics. The one in South Africa, I like the name. It's funny. It's called, so you want tibia orthopedics, you want to be surgeon. In Saudi Arabia, we do something called the fixers. So we did that course for all medical students, and as you can see, there is diversity. So it's not all females medical students. We do mentor males and females by males and female surgeons. We teach them how to use the drill. We teach them how to play with arthroscopy, which is the fun part. And these are the tweets of actual medical students who were tweeting saying that this is the funnest day, and we had so much fun, and we learned a lot. We mentor female residents. As you can see, my protege is here, where there is a consultant in each region, and they can come and reach to us about each and everything, even if it was for just simple social gathering and venting and talking about what's happening around their week. So what do you do as an established orthopedic surgeon? How do you help diversity, like Jenny was saying? So this is something that Dr. Sufyan did very nicely, is just having females in the panel. So when you decide to make a course, please look for females. We're not just saying, as Christy was saying, not just as checkpoints. No, please find women who are worthy and good enough and make them be there and being represented. Do not discourage female medical students and give them the proper tool. So I made the guys give you cards about the IODA website. It is for free, and it has a lot of data and papers about women and X-ray protection, women getting pregnant during the program, and a lot of studies that you can get for free, and you can give the girls and the students the tool to choose correctly. If you are in the training program, please make sure that your program is a bit flexible. And as you can see, women who are pregnant are tweeting that they are, even although they are on the 2nd or 3rd trimester, they can still go into the OR wearing the proper X-ray protection. And of course, if you share our website, you will find the screen around the world or the world map, and you have a representative of diversity each around the world, and we can get you into contact with whoever and whatever you need. You can share this hashtag about your team, showing that your team is diverse, having males, females, black, white, all shapes and sizes. It's called Look Like a Surgeon or Look Like an Orthopedic Surgeon. And thank you very much. And we'll listen to the Tunisian experience with Dr. Miriam.
Hello, I'm Mariam I'm an orthopedic surgery resident from Charles Hospital, third year, and thank you for having me today. So, can I have to talk? I'm here to talk about the Tunisian experience. It's a bit personal, what I'm going to talk about. Okay, diversity in orthopedics. So, diversity actually includes all minorities, not just women, but our medical schools in Tunisia, just like orthopedics, they welcome all backgrounds, all ethnicities and races and orientation. So we have a major diversity issue in orthopedic surgery in Tunisia and worldwide, which is a lack of females. Orthopedics remains a male-dominated specialty, and female trainees considering a career in orthopedics are confronted to barriers and challenges in relation to their gender. Okay, so worldwide, I tried to look for some percentages around the world. In the UK, 7% of orthopedic consultants are female. In USA, there are 13% of them. 4% are members of the American Association of Orthopedic Surgeons. Yeah, I'd like to have the screen, please. So, in France, female orthopedic surgeons account for 7.1%, and according to the International Orthopedic Diversity Alliance, well, I thought it was Estonia at the first rank, but it's Germany 27 and Estonia is 26.4%. So, in Tunisia, currently there are 15 female orthopedic surgeons, 12 of which are still residents, which is 6%. So we are matching the European numbers. This gap is getting smaller every year as 3 to 4 female physicians join the residency program. But our specificity here in our country is that this number is worrying because up to 70% of medical school graduates are female, yet a handful of them choose orthopedics. Okay, so what barriers are women facing? Physically, it's a physically demanding field. Exposure to radiation with lack of protective gear in our hospital and educational programs about radiation hazards and how to protect ourselves. And it's an unconventional choice of specialty, still not accepted within the community. Patients sometimes refuse. And the medical paramedical underestimation. I had actually some patients who were complaining because I was fixing his femur. He demanded a male surgeon. But women have a free choice to enter orthopedic field according to their rank in the exam, and seniors treat them according to their competence, skills, and knowledge. They are encouraged to pursue a teaching career and occupy leading positions. Gender issues. So I tried to see what kind of issues I was facing daily since my first year, and I looked through literature and worldwide whether these issues were faced by other female orthopedic surgeons throughout the world. And physical strength came up as the first issue. So orthopedics is more physically demanding than other specialties such as ophthalmology, but modern day techniques and technology have made it easier for women to operate. And as Dr. Lisa Latanza says, you have to be smarter than the bone, not stronger than the bone. You use body mechanics and leverage when you need additional force. So, and microaggressions, actually, 70% of female orthopedic surgeons had experienced microaggressions from patients, families, male surgeons during their training. Inferiority assumptions, they directly and automatically presume you are less able to fix them, to reduce them, and to get them back on their feet because you are a woman. 58% of female surgeons were mistaken for a nurse. I get called daily nurse in the hospital or another medical or non-medical profession, but not a surgeon. 47% felt they were treated more negatively by nurses and other female workers in the hospital, in the ward, in the consultation, or even especially in the operative theater. And dismissed capabilities by men. Difficult tasks also sometimes were commonly assigned to male colleagues. Work and life balance issues. A study in the USA found that one of the most common reasons for women not choosing orthopedics as specialty was the inability to have a good work-life balance. They cannot take care of their family, they were unavailable for family needs and obligations, they had difficulties maintaining relationships, and they had inflexible training infrastructure. Exposure to radiation and teratogenic chemicals just like cement, PMMA, or pregnancy. So occupational hazards, fetal toxicity, and fertility issues are met with on the daily in our practice. Appropriate protective measures are usually present, but not all the time. In 2020, the BOA, British Orthopedic Associations, reported that 75% of females felt there was a significant compromise in training during pregnancy due to intense workload, 55%, inappropriate cases out of hours, 25%, difficult on calls, and a large USA survey found that 48.4% of female orthopedic residents deferred having children due to training, and almost 60% experienced bias against pregnancy from co-residents. Okay, but it is important to highlight that female orthopedic surgeons are just as competent as males, with studies written by men showing reduced post-operative complication rates and mortality in patients operated on by female orthopedic surgeons. So the integration efforts, during my training, on the surface there were no active efforts to integrate women into the specialty. It's a left out issue, and the choice of career was sporadic by previous female orthopedic surgeons. They had an early brush up with the specialty. They had early targeted guidance in med school by invested seniors who saw potential in them and guided them through the specialty and encouraged them to choose this. But most medical school graduates ignore the presence of female consultants and thus the lack of idealized figures. Individually, consultants, senior residents, and department chiefs are welcoming women and encouraging their evolution in the field, and this is what I felt. So in conclusion, orthopedics has the lowest representation of female physicians. We have to recognize the factors affecting uptake of women to the specialty in order to increase diversity. We cannot develop as a profession unless women are completely included, respected, and leading, but they should not be singled out as a gender, but as surgeons. And thank you. Mike.
Christy and Jenny are with us online, and we're happy to take any questions. تفضل. The mic.
I do agree with you that about the problems that the female surgeons, orthopedic surgeons, are facing, but I think the same problem the male gynecologists facing from the society. A lot of families refuse to be seen, their females to be seen by male gynecologists. And the people, the society that looking at the male gynecologists, same as they're looking at female orthopedics. So it's the same problem the males gynecologists having.
I have just comment because I was the initiative of this program, and I have chosen this topic since the first meeting that we had in our society. Since Tunisia was always a leader in debating about females since our independence, and as a country where the incidence of female is important. And there are some specificities in our country, maybe in the scientific field, where the incidence of female is very high. If you see the incidence of females in residency program, it is more than 50%. Then we have more than 50% of residents which are female, but most of females are choosing other specialties than orthopedic. But I think there is a bias in this factor that these specialties considered as male and need strong guys now. But I think things are changing. Fortunately, we have a young leader surgeon, and the incidence is getting higher and higher in Tunisia. These young ladies like Miriam are really debating and competing very well with the guys, and mentality is not really changing, because we are really accustomed in Tunisia to see women in all the fields, but they remain underestimated in the high-ranking positions, either in the finance or business or whatever what the field is. But I think the regulation is changing. Debating about diversity is getting more and more important, and I think in 2023 we will have we will be the first country, Islamic country, to have the obligation to have representative in each type of field of female in the high-ranked, like CEOs or CCOs or something like that. But in Tunisia, it's very particular in this country. But in Libya, we have a huge number of residents, more than Tunisia at the moment. But we have to see more and more in the next few years. Yes, I thank Jennifer and Christy to be here with us for this debate, and hope to see you in Tunisia one day, maybe, and to celebrate the higher incidence in Tunis.
Thank you so much.
Okay.
Yes.
Thank you.
Look forward to visiting.
Look forward to see you in Tunis.
Thank you.
Okay, bye-bye.
Bye.
So we'd like to thank Dr. Christie and Dr. Jennifer for the amazing talks, and just being there as role models, having led the society in their areas. And as you said, as Dr. Sufyan is saying, you have to come. The weather is amazing and the food is great. So we'll hope to see you soon.
Look forward to it. Thank you very much.
Okay. So now we're seeing new regulation in bone banking in Tunisia. So bone allografts have now more than 30 years of insights, which allows us to have better knowledge of its potential and limits. It's now well known. We now know for sure its proven efficacy. In 2007, for example, more than 18,000 bone grafts were done in France, but it's still subject to strong health constraint, which means we have to have clear indications and well-known techniques. For history, in 1668, the Dutch doctor Jacob van Meckering performed the first bone grafting operation on a soldier with a damaged skull. He used a dog bone as implant material, and the bone defect healed well. Unfortunately, the soldier was excommunicated by the church for being part dog, and he requested to remove the graft. That's how the doctor discovered how well bone grafting actually worked. Later on, in 1858, Ollier in France published the first scientific study on bone grafts. 20 years later, McEwen in Glasgow did successfully the first bone allograft from human to human. From the 20th century, with the advent of antibiotics, and from the 80s with chemotherapy, tumor surgery and prosthetic surgery, the use of bone allografts became more common use. So we won't spend much time with the usual indication of bone grafting, like bone reconstruction in the acetabulum for total hip arthroplasty, or femoral reconstruction. Here's an example of the Exeter technique. The bone graft is impacted in the femur to help maintain the femoral component. Bone reconstruction is also used in revision TKA, or also in tumor surgery. Here's a case of osteosarcoma in distal femur that was reconstructed with a block bone scalded from the femur, a block femur. or we can also use crushed bone, like this example of osteoblastoma in a young patient. Bone grafting is also the solution for most of non-unions, like the intertibiofibular grafting or bone reconstruction in bone loss. There are some other newer indications, like lumbar interbody fusion. Bone cut from the femoral head has shown good shear resistance, and good results are obtained with lumbar interbody fusion with no cages needed. Some other team describe the fusion of the ankle using a femoral head bone. So the talus is totally resected, and an acetabular reamer is used for the distal tibia and for the calcaneus. And then the talus is totally replaced with the femoral head, thus making the correction of the angle more easier, and the fusion is performed with the transplantar nail. And finally, another interesting indication, the Müller-Weiss disease. The necrotic navicular bone is totally resected and replaced by a new bone carved from the femoral head in the shape of a navicular. Then it is fixed with screws and plates. Next, I give the floor to my colleague, Dr. Mehdi Karas.
So welcome, I'm Dr. Geddes Mahdi, microbiologist and responsible of tissue bank in CNPTO, Tunisia. So I will present to you the activity of the CNPTO and the tissue bank. And some of legislation in CNPTO, National Center for Promoting Organ Transplantation, the functions of CNPTO, femoral head grafting activity, and activity outlook. The constitution of CNPTO was legally constituted in June 12, 1995. There is in 1991 another law for regulating organ grafts. There is a decree in June 97 for administrative and financing organization of CNPTO. In March 1999, the indication of mention of donor on identity card. And in 2004, relative to organ and tissue graft, transportation, conservation, and attribution of grafts. The CNPTO functions according to 1995 law. The CNPTO have the following function. First, edit practical modalities of organ preservation and graft. Second, promoting organ donation by sensibilization of Tunisian public with the collaboration of associations. Third, the training medical and paramedical staff on organ transplantation. Four, registration of patient expecting for an organ graft. And fifth, attribution of organs to patient according to a specific score, like blood group, HLA type, age. The organization of CNPTO, there is the director and 3 units, tissues bank, national coordination of multi-organ graft, and training and sensibilization unit. For tissue bank, there is cornea bank, tissue bank, for femoral heads, amniotic membrane, and soon cardiac valves and vessels. For a unit of training and sensibilization, it deals with training medical and paramedical staffs, sensibilization on organ donation. For the bone bank activity, there is a network of hospitals elevating femoral heads bones in Tunis, Mohammed Qassab, Munjisim, Marsa, La Rabta, 5 hospitals in Tunis, and national network of elevating femoral heads bones. There is in hospitals in Nabil, in Sousse, in Kairouan, Monastir, Mahdiya, and Sfax, who provide head bones. Evolution of femoral head bones activity from 2002 to 2021. There is a lack of bone providing from 2008 until 2011 for technical problems, but in 2021 we have treated 90 bone head. Tissue bank structure, there is an area for reception and distribution for graft zone. There is a zone for tissue preparation with the controlled atmosphere, ISO 7. This area is controlled and qualified periodically for particle control and microbiological air and surface control. There is an area for storage, cryoconservation on minus 80 degree and conservation on plus 4 degree, controlled by refrigeration surveillance system. And there is a decontamination area for instrument disinfection and sterilization. Different stages of femoral head bone treatment. First, we do femoral head decortication. Second, we measure the femoral head. Third, femoral head conditioning and for microbiological samples, for microbiological controls and viral serology. Fifth, there is storage of femoral heads on minus 18 degrees Celsius. And sixth, carriage of graft to hospital must be done with carboglass, which keep temperature at minus 18 degree. We have an activity outlook. Legislation for grafting femoral head bone in private sector must be updated because the legislation is not updated. Lyophilized bones can be treated in our center if orthopedists are interested, and after acquiring the suitable instrument to prepare this graft. And thank you. Is there any questions?
Thank you very much for your presentation, Dr. Mahdi. Is there any question from the audience, please, regarding bone bank? Question for me, like, how many bone banks you have in Tunisia? Do you have bone bank per se? Bone bank, how many do you have? Oh, we just have one center, only one center. And serving all. Okay.
We don't have national bank. So. Yes, there is no other. Only one bank, okay. National, in Tunis.
Yeah, thank you very much. Who's next? Next lecture. Understand? Okay. Thank you. Thank you very much for your attendance.